Thank you, Cecilia. And I also want to say thank you for having me here, for being here. I saw the first slide, I think, this morning where the goals of the Breast Health Global Initiative were laid out, and one of the issues was economic, affordable, and culturally acceptable care in breast cancer. I'm a health economist, and as such, I hope to add a little bit to the economic, feasible or affordable issues to this conference. I will focus, of course, upon the cost-effectiveness analysis and social health protection in breast cancer in the study that Cecilia just before me laid out. Just real quick, cost-effectiveness analysis addresses the efficiency question in health, as in low and middle-income countries, we have a certain budget which we can use to buy or spend on healthcare, and of course we want to make sure every dollar or currency that we spend is spent effectively. The main questions, therefore, in a cost-effectiveness analysis is how can we get the biggest bang for the buck within healthcare? In light of the previous presentation by Mrs. Ann Reel, I would like to say indeed that when it comes to low and middle-income countries, the affordability issue is a very important one. As you may know or may not know, healthcare costs in low and middle-income countries are the most important reason for people to become impoverished. Studies have shown that in Southeast Asia, every single year, over 70 million people are being pushed into poverty solely because they cannot pay for their healthcare costs. When they become ill, cannot work, no insurance is there. So all these things also have to be taken into account, I think, or are very important when looking at breast cancer healthcare. That said, it should be stated that cost effectiveness is, of course, only one input in the decision-making process, other areas being equity and other priority-setting criteria, like, for instance, the budget impact that a certain intervention will have on the finances of a healthcare system. As such, cost-effectiveness analysis can help to guide the growth of resources for health care interventions towards universal coverage. A little bit more about the cost-effectiveness analysis that we are carrying out. It is based upon the WHO Choice Project, which shortly stands for Choosing Interventions That Are Cost-Effective. And you should know that CHOICE is WHO's work program on cost-effectiveness, and as such it uses a common set of tools and methods which help to enhance the comparability between diseases and or risk factors. It is sectoral and on a population level, meaning effectiveness is being measured by the healthy years gained or the dollars averted, disability adjusted life years. I'm sure some of you are familiar with this concept. It takes into account both additional longevity as well as quality of life, and the resource costs of patient and program level. So implementing a program for healthcare, of course, has program costs with it, but also costs that can be related to the patients, like medicines and days they spend in hospitals, etc. The results of this WHO Choice program, because several studies have been carried out in this program, are summarized in WHO regional cost-effectiveness databases, and they are available for country-level adaptation and analysis. And this last part is important when we look at the project that we are working on, because we are a little bit about the application of WHO Choice. It can be done by disease and by risk factor. We are doing it, of course, by disease, looking at breast cancer only. And the WHO Choice program is organized as such in a geographical setting, which basically means WHO has generated, based upon its 14 sub-regions in various levels of health, and those are based upon, I believe it was child mortality rates and incidence rates of various diseases, as well as the 6 World Bank regions that have that group countries together that are comparable when you look at incidence and prevalence rates of certain diseases. Therefore, a large database has been generated that can be used to do these kind of analysis. And basically, you see the several groups on the map right there, and every color sort of is comparable in the sense of incidence, prevalence rates when it comes to various diseases. However, what the previous slide showed, and let me go back real quick, they are available for country-level adaptation. And that is what we will be doing or are doing within this project. So, you see several countries listed there as well, because the WHO Choice Project can be specified or tailored to a country-specific situation. So what we do for the 3 countries that we have preliminary results for, we go to the specific country, we try to identify the most latest or the most recent incidence, prevalence rates, etc., stage distributions when it comes to breast cancer, of course, and we try to implement or put those data into the model that we have developed together with the University of Nijmegen to do our final analysis. Usually those models are filled with the regional data, and what we try to do is to put country-specific data into the model and then see what the outcomes are. About this model, just very briefly, the population is tracked over their lifetime and maybe in different health states. So we've got healthy, we've got breast cancer, and breast cancer then is divided into 4 stages, and people who are deceased. We look at or we try to estimate the impact of several interventions, about which I will talk a little bit later on. First, we estimate the population health in a baseline scenario. That's basically the current scenario in a specific country. What kind of care does a certain country have implemented so far, and what does it give us in terms of health outcomes? Then we estimate the population health once we implement those various scenarios that we modeled. And then, of course, the difference in health outcome is the impact of the intervention. The interventions are implemented during 10 years. So for 10 years, we are basically measuring the impact of the intervention as well as the cost. And based upon those, we calculate what is called a cost-effectiveness ratio. So once again, we have the population at risk. And there's an incidence, and incidence for every specific stage. And in each stage, there is a disability weight, basically meaning your quality of life is affected depending upon in which state you are. If you're in stage 4 and you have metastasis, of course, your quality of life will be much lower than when you're in stage 1. And these measures are being taken together to calculate the outcomes, namely the disability-adjusted life years that we avert. I will talk a little bit about that in the next slide. Finally, we have a case fatality rate. Of course, the case fatality rate is higher for people who have metastasis than people who are in stage 1. And also these rates, we try to find out what they are for the specific countries. Instead of using regional data for several group of countries, we try to figure out what is the case fatality rate for a certain group of breast cancer patients within a specific country.